Good evening. My name is Claudine Lewis. I'm a respiratory therapy student, and I'm here to go over my case study with y'all. I met this patient on November the 3rd after he came off of the vent. So he's 74 years old. He was found October 31st, unresponsive by his brother and brought to the emergency room. He's a full code. When he was brought in, he was unresponsive to pain and in severe respiratory distress. He was diagnosed with cancer in June, lung cancer to be specific, non-small cell carcinoma. When he was admitted, he had a blood pressure of 63/30. His temperature rectally was 94.4. They originally did BiPAP on him in the emergency room, and he responded okay to that, but then they decided to put him on a vent. And he actually sat up when they took the BiPAP off before they got him sedated. So he was tolerating it pretty well. His medical history includes hypertension, COPD, lung cancer, which has metastasized to his pelvis. He was a farmer. He has not quit smoking. He smoked 2 packs a day for over 50 years and then has cut back to less than a pack a day in the past 6 months since being diagnosed with cancer. According to our Egan's textbook, page 635 and 636, tobacco is responsible for 85 to 90% of cases of cancer. Other extenuating circumstances include genetics, COPD, diet, and occupation. So maybe pesticides or whatever he sprayed during while he was farming, who knows, or even fertilizers. It's got about a 5-year survival rate, 73%, if it's stage 1A, and that's on page 645. Chemo and radiation are not as effective as surgery. Surgery is the first option if it's at all possible, which it was not in this patient. So his breath sounds were kind of diminished throughout, typical COPD lung sounds. Heart rate was 88, respiratory rate was 18, SpO2 was 99% on 40% on the vent. When he came off, he was 93% on a nasal cannula at 4 liters a minute. His blood pressure was 140/70, and his temperature was 98.4. So when he was admitted, the initial arterial blood gas showed a pH of 6.99, PaCO2 of 86, PO2 of 45, and bicarb of 20. They did, that's acute respiratory acidosis, and there's an interesting article on mercksmanuals.com from March of 2018 by James Lewis, MD, talking about how respiratory acidosis is caused by an increased PaCO2. It's caused by hyperventilation, central nervous system depression, pulmonary iatrogenic, I can't read that. Chronic respiratory acidosis will not be symptomatic, and the only real treatment for that is oxygen and mechanical ventilation. Causes are obstructive, restrictive, and parenchymal and pulmonary disorders. The only treatment is to ventilate. Bicarb is contraindicated. COPD is a common cause. You treat and provide adequate ventilation until you can treat the cause of it. It was found out through a chest X-ray, which I will send in my attachments, on 10/31 that he had infiltrates in both lungs, especially on the right. He had really long, dark-looking lungs, really wide spaces between his ribs, and V-shaped clavicles. I didn't see anything that looked like cancer tumors, but I'm not really sure what I'm looking for on that. Remember, his body temperature was 94.4 when he was found. There's a neat article on acutecaretesting.com by Chris Higgins that's talking about doing arterial blood gases and correcting for the temperature. Most blood gas machines will bring the blood up to body temperature, 237 degrees Celsius. But being hypothermic is actually common. In 10% of critically ill patients, they'll be 35 to 36 degrees Celsius. Hypothermia is common in sepsis, being exposed to cold, endocrine emergencies, and overdoses. According to Henry's law, decreased temperature causes an increased solubility of O2 and PCO2 and increased hemoglobin affinity. So as a result, the hemoglobin will hold on to the oxygen and not release it. It causes a left shift of the oxyhemoglobin dissociation curve. It impedes delivery. So the hemoglobin's picking it up fine, but it's not giving it up to the tissues. So it was found that he had pneumonia, which probably led to sepsis. An odd tidbit is he was seen in the cancer center for treatment the day before he was admitted to the ER, and they found him to have to be hypotensive. And all they did was give him fluids and send him home. So according to a nifty article on merckmanuals.com by Larry Bush, which is also going to be in my attachments, there are over 90 types of pneumococcal pneumonia. Risk factors include sickle cell anemia, HIV, or anything that involves immunosuppression, which would be any kind of cancer drugs. Chronic illness, which in his case would be the COPD and the cancer. Long-term care facilities, smokers, which he's still currently a smoker. The elderly have a poor prognosis for pneumonia. It can also cause ear infections, sinus infections, meningitis, and endocarditis. The fatality rate is actually 30 to 40% in the elderly population. It's the most common cause of community-acquired pneumonia, and the only way really to prevent it is a vaccine. Continuing to look at his stuff, they did a CT because he did fall, and they were wanting to rule out any head or neck injuries, and everything was clear on that. He had multiple chest x-rays. 1031, there was some infiltrates. 10-1 was better. 10-2 was 11-1 was a little bit better. 11-2 was worse. There was some atelectasis happening because the vent settings weren't quite good enough. So they increased the tidal volume a little bit, and it improved on November the 3rd, and he was extubated. I did mention that his cancer had metastasized a little bit. His white blood cell count on October 31st was 12.5, which is elevated. His red blood cell count was 3.34, which is kind of normal. His hemoglobin was 10.1, which is low. His hematocrit was 32.9, which is low. His BUN was 31, which was high. Everything else was pretty much within normal limits. His ABG improved a lot. They did multiples while he was there. The last ABG on 11-3 showed a pH of 7.39, a CO2 of 50, a PaO2 of 99, and HCO3 of 30. So he's compensating. And he's probably closer to his normal CO2. His is going to be higher since he does continue to smoke. Let's see what else. He had Streptococcus pneumoniae. I'm having a really hard time saying that. They didn't do any pulmonary function tests, which I would like for them to have. That would have been very, very nice. But if they had, in the Desjardins textbook on page 384, it says pulmonary function tests can show obstructive or restrictive values. If the cancer is obstructing a major airway, the pulmonary function test will show an obstructive pathology, especially if there's COPD as well. But if there's a lot of tissue involved, it's going to show more of a restrictive pattern. And his normal medications are not crazy. He takes Ventolin as needed. Trelegy Ellipta, which is one of the newer inhalers, it's got 3 medications in it. I've started seeing commercials for that on television. It's for COPD. He just takes it once a day, 1 puff. He's on O2, 2 liters a minute at night only, and he takes lisinopril for his blood pressure. He's on hydrocodone, acetaminophen, some people call that Tylenol 3, for pain. During his hospital stay, he just got Duoneb and suctioning as needed for bronchodilation until they could get him stabilized enough. I would say that the treatment was very effective because he was able to come off the ventilator. hopefully in the future. And when I saw him, he was actually sitting up, eating ice cream, and was very thirsty and wanting his dentures. He's stable. He still looks crappy. I mean, he's just your typical COPD appearing patient as far as he looks cathetic and thin and frail and pale. Um, he's stable at this time. The pneumonia's reversed. The sepsis has been reversed. I think he was going to be downgraded to IMCU, and they're going to evaluate him, of course, to see if he can go home or what. I think he should discuss with his family what his final wishes will be, because if he had not been found and had not been resuscitated, it would have been a very different outcome for this patient. I don't know if if he'd had a stroke or something while in the vent, it would have been much different prognosis for him. If he hadn't, been ventilated appropriately, if he hadn't been found when he was, he probably would have passed away, especially with that low of a body temperature. He was not doing very well. So I thought this was one of the neater cases I had seen while I had been in clinical, just because he had a lot of mixed stuff going on, and I haven't seen anyone with that low of a core temperature. I realize it's not as low as it could be, but I thought that was pretty interesting that he was able to come back from that, and just wanted to share that case with y'all. Thank you.